presenting about the initial assessment and imaging protocol. So before I talk about the inpatient management, I would have a quick look about the pre-hospital management of the spinal cord injury. So 25% of the spinal cord injuries happens after the initial trauma. Therefore, it is important to handle the patients in the correct way. So here I have illustrated an image, illustrated a table which shows how the cervical spine has to be cleared by the first responders. So once the cervical spine is cleared, if the cervical spine is not clear, then we have to immobilize the spine, and then the patient has to be transferred to the facility. And according to the latest guideline, a hard cervical collar and long board immobilization is preferred rather than the previously used methods. For in-hospital assessment, we have the primary survey followed by the detailed assessment and then the imaging protocol. In the primary survey, we follow the ATLS guideline where we look for the catastrophic hemorrhage and then we look for the patency of the airway. At this step, we also make sure the cervical spine is immobilized. If we have to shift the patient, we use the top roll maneuver. And in the breathing, we check for the ventilation, and in the circulation, we check for the perfusion, followed by the disability where we do a quick neurological exam, we assess the GCS score, and then we also look for the pupil. We make sure that we check whether the pupil is equal and reactive to light, and in the exposure, we completely undress the patient and assess the patient for any kind of injuries. Following the initial assessment, we have the detailed assessment in which I will be talking about the pertinent history, initial assessment, the spinal examination, and followed by the neurological examination. So when it comes to the pertinent history taking of the spinal cord injuries, we have to know the mechanism and the velocity of the injury, onset and the duration of the neurological. Also, we have to know about the surgical history of the patient as well. In the initial assessment, is the one I previously discussed, is the primary survey of the ATLS. In the spinal examination, we inspect and palpate the spine for any kind of tenderness, for any kind of abnormalities, and also in this step, we have to do a rectal examination as well. Next would be our neurological exam. So when it comes to motor exam, we have to test all the testable myotomes using MRC gradient of 0 to 5. And when it comes to the sensory exam, we check all the dermatomes for the light touch and pinprick sensation, and here we are grading it from a grade of 0 to 2. And if it is not testable, we just simply write NT. So all the data we have collected from the neurological exam, which would be put into the Asian neurological classification, which helps us to standardize and assess and classify the spinal cord injuries. So it gives us an idea of our treatment plan, and also it gives an idea of the prognosis of the patient in the long term. So this was previously discussed by the Dr. Shauna, so I wouldn't go in depth of this. So in this category, we have 5 categories of Asian neurological impairment. Last but not the least, I would be talking about the imaging modalities. So in here, I would be discussing about the NICE guideline. So the patient who has to go imaging would be high risk. Any patient who has a high risk factor for cervical spine injury, which is identified and indicated by the Canadian C-spine rule, or a low risk factor for cervical spine injury who is identified and indicated by the Canadian C-spine rule, and the person who is unable to actively rotate their neck 45 degrees right or left. So the high risk factors include any patient who is 65 years or older, and if the patient who is involved in dangerous mechanism of injury, which include high velocity collisions or fall from 1 meter of height, and paresthesia in the upper or lower limb. And low risk factors include involvement in a minor rear and motor vehicle collision, and if the patient is comfortable in a sitting position or ambulatory at any time since the injury, and if there is no midline cervical spine tenderness, and if there is delayed onset of neck pain. So if the patient has to undergo imaging, so for the children under 16 years for cervical spine, the first modality would be MRI. So if the patient is not qualified to do the MRI, but still we have clinical suspect of cervical spine injury, then the next modality would be the plain X-ray. So adults with cervical spine injuries, the golden standard would be to do a CT, and if there is a neurological abnormality, then we have to do MRI even if the CT is negative. For suspected thoracic or lumbosacral column injury, the first investigation would be X-rays. So we will do the X-ray of whole spine, and then we have to do CT if the X-ray is abnormal or there are clinical signs in terms of spinal cord injury. And if a new spinal column fracture is confirmed, then we have to do the imaging of rest of the spinal column, because 15% of the times there is injury at another level. When it comes to whole body CT in adults is recommended with blunt major trauma and suspected multiple injuries. So a patient should not be repositioned during while taking the whole body CT. And we do not routinely recommend to do whole body CT for children under 16. These are my references. Thank you for listening.